If you work with breastfeeding families or you have a baby yourself, you've probably had that moment of wondering, is this baby reacting to something? Gas, reflux, rashes, mucus in the stool, discomfort, unsettled feeds. Sometimes food reactivity is part of the picture, and sometimes it isn't. But guessing can leave families overwhelmed, confused, and unfortunately, afraid to eat. That's why I am excited to share Map My Milk, an app created by an occupational therapist specifically for breastfeeding families. Map My Milk helps parents track what they're eating alongside their baby's symptoms so families and providers can start to see patterns with more clarity and less guesswork. It's also a helpful tool for practitioners to recommend when food reactivity may be part of the picture or when you're trying to rule it out. Map My Milk has partnered with Dr. Trill of Free to Feed and has connected with hundreds of lactation consultants since launching. Try it for free today at mapmymilk.com and use code TONGUETIE20 for 20% off your first month. Welcome to the season marking 4 years of the Tongue Tie Experts podcast. I'm incredibly grateful for what this space has become. What started as a simple idea to create thoughtful, evidence-based, and multidisciplinary conversations about tongue tie, infant feeding, and airway-centered care has grown into a global community of professionals who are committed to doing better for babies and families. Over the years, I've had the honor of sitting down with parents, lactation consultants, dentists, birth and medical professionals, therapists, researchers, and educators from around the world. Together, we've explored the science, the controversy, the clinical nuance, and the very real human stories that live at the heart of this work. My hope has always been that this podcast supports you in thinking critically, collaborating confidently, caring more deeply, and helping more people. If you're new here, welcome. I'm so grateful that you found us. To those of you who have been listening, sharing episodes, and sending messages over the years, thank you. Your support is the reason this podcast continues to grow. To our guests and sponsors, special thanks to you for your incredible contribution to this mission. Let's see how long we can keep this going. Please click, follow, leave a rating or review, and share with a colleague. It truly helps this podcast reach more who need to hear these insights. Now, let's get into today's episode. Hi, everyone. I'm your host, Lisa Palladino. Welcome back to the Tongue Tie Experts podcast. Today, I'm going to introduce Dr. Brynn Leroux, who I consider Dr. Leroux a conference buddy because we always see each other at conferences. We've never met outside of a conference, so this is a special time. So Dr. Leroux is a board-certified pediatric dentist with advanced training in pediatric laser dentistry, tethered oral tissues, airway-centered dentistry, sleep medicine, and interceptive orthodontics. Dr. Leroux completed her pediatric dental residency at the Medical University of South Carolina, where she served as chief resident. She is also certified by the American Academy of Laser Dentistry. She's TOTS trained and a founding member of the International Consortium of Oral Ankylofrenula Professionals. In her practice, she evaluates patients for signs of tethered oral tissues and sleep disordered breathing and provides laser, lip, and tongue tie releases for people from infancy through adulthood. So welcome, Dr. Leroux. I'm thrilled to have you here today. And I can't wait for my audience to hear your lovely accent.
Oh, here's a Southerner. The Southerner is here. Oh, thank you so much for having me. I am excited to be here.
What's going on?
I'm good. It was a bit of a slower morning, which I appreciate. I can catch up on a little work, but I have some babies waiting for me once we finish up our interviews. So it's a good day. Summer starting in the pediatric dental office. So that's when things get to be really busy.
Everybody's taking care of their dental needs during the summer.
That's right. That's right.
So one of the things that I thought would be important to talk about is I mentioned in the intro, you're an ICAP founding member. We're both, I was there in the beginning too. I kind of left while things got a little hairy and came back in, but we've all, we all value ICAP, and I speak about ICAP so much on this podcast. But the most exciting part of ICAP to me is the research going on. So
absolutely.
At our last conference, which was just a few weeks ago, we found out that there's a way that practices are collaborating on research. So do you want to tell me a little bit about that? Because to me, that's so exciting. This is what's going to move our field forward.
100%. This is where we gain credibility, right?
Mm-hmm.
So I'll back it up a little bit to when I was chair of the board many years ago, and I met Dr. Ray Singh, and he's very special in that he's a pediatric dentist and he has a PhD and very heavily research minded. He gave the proposal for starting the serious research branch of ICAP. And we approved that, and we got to be very close friends and colleagues, and really the rest was history.
Dr. Singh has been on the podcast too.
Oh, awesome. I'm sure he has. And then, we have a few PhDs now that work with us with ICAP and Sirius. But I personally, I'm a very, clinically minded person. I've never actively participated in a research study outside of what was required of me in residency and in dental school. But I know this is needed so much. And I know that I have a lot of information and data and things to contribute. I just don't know what to do with it. So when Dr. Singh asked for me to participate as one of the locations who would be helping to collect data for the project, I was really, really excited to do that. So it is an international research project, which is really exciting because we know that people do things differently all over the world. And we, especially being an international organization, we don't want to be accused of being too American or North American centric, basically. So Dr. Duke Lamdeau from Montreal, Canada, and myself and Dr. Singh's practices are the main participants, but he's also pulling data from other practices in other countries. I think mainly Australia, where Dr. Smart is, because we just need more data and information. But he wants to look, or they want to look at not just pre and post-op stretches, but what happens if you only do post-op and you don't do pre-op stretches and exercises. And it's difficult for us as practitioners who really feel like we get the best results with pre and post-op therapy to not have a certain section of patients not do the pre-op therapy. So that's where he's pulling other practices where that's just their routine way of doing it to be able to get their data without us compromising what we feel like is best for our patients.
That's so important, because one of the challenges in this therapy, in this research for these therapies, is we never want to deprive someone of what we feel is best practices in order to get some research, right? It's
100%.
Like you can't say, oh, I know your baby has a tongue tie, but I'm not going to release it because I want to put you in this study. That's terrible.
Correct.
First do no harm, right? So,
that's right.
One of the things that's intriguing to me, this whole topic of reattachment and needing re-releases, which then we call a revision, and also, I just did a lot of my own research on that because I did a whole episode. I'm not sure if that episode will air before this one or after it, but I wanted to see what the research was out there, because there's so many people saying it doesn't matter. It doesn't matter. It doesn't matter what you do. And we know from some small studies that it does matter, and now we'll have bigger studies to see it. And also at the same time, in my own life, as I told you before we started recording, my own granddaughter had a release yesterday, and her mom is timid about the stretches. So I was just over there doing the exercises and stretches with her. And I was thinking to myself, I can only imagine how hard it must be for a parent who doesn't truly believe this is necessary, or is getting mixed messages from media, from Instagram, because, that's how most parents learn these days. all about you don't have to do this, you don't have to do that, and then the other problem I found, and I'm sure this will be clarified in your work, is defining what we mean, right? Like aftercare can mean a lot of things. Stretches
Right.
can mean a lot of things, right?
Correct.
So standardizing what works and what doesn't work. And this
Absolutely.
is so exciting and important work that you're doing.
Yeah, I'm excited about it. So when we all first met, we shared with one another what we do specifically in each of our practices, and then made sure we put something together that kind of hit on what we all do. And we are giving parents access to a QR code that like
Mm-hmm.
lists out all of the stretches and exercises. So we know every baby's kind of getting the same therapy. Whereas how I typically practice when not participating in the study, I have a list of things in my mind that I think will help prep this baby for the procedure, or this child,
Mm-hmm.
not just baby.
Mm-hmm.
And I'm not a therapist, I'm a release provider, but
Right.
I'm the structure person, but I know some things about function, and the therapist is the function person, but they know things about structure, right? So a lot
Mm-hmm.
of people come to me first before they see a therapist. So I try to give the families things to be doing to start prepping the child for release, before they even see the therapist. So it's just a little odd for me, because I usually have my like things that I think are specifically tailored to each patient, not just a cookbook.
Mm-hmm.
But with this, we're
Mm-hmm.
doing more like a cookbook, just so it's standard for the research study, which means they're doing more, not less, actually. But it'll
Right.
be
So
really neat to.
yeah, because you have to standardize it in order for the research to work,
That's right.
right? Yeah.
That's right.
And that's what's a problem with so many studies, that there is no standard. Like the study that came out that mentioned, I'm not going to, I don't know this study offhand, but it mentions massage. Like, what the heck do they mean by massage of the wound, right? That could mean
Mm-hmm.
anything,
Yeah,
right? They
that's
didn't
right.
define what it meant. It was also in a different country than ours, so maybe the translation wasn't right.
Could be.
So yeah, so things like that are so critical in making sure that it's standardized and we define what we're talking about, because otherwise you can pull information that sounds like a headline
That's
and
100%
really
true. Yeah,
and so shake up our worlds and disturb parents and make us question our practices. But
that's right.
we know what we know clinically by watching the wound, right? Like,
That's
so
right.
day 2 today on my granddaughter, I could see that there's some fibers that were there, and as I stretched it open, the fibers were gone. So like, what if we should just let it be? No, we shouldn't just let it be. We should handle it. We should do something to prevent it from healing closed so fast, because that's how babies want to heal. So we know what we know, and we know what we've seen for years and years and years in
That's
clinical
right.
practice, but now we're going to have some data to support that. Many professionals were never taught how to fully assess tongue tie, and families are often left trying to reach their breastfeeding goals without the support they actually need. If feeding feels harder than it should, I don't want you to be alone. I wrote Tongue Tie for Parents to help you understand what's happening and how to move forward with a clear, thoughtful approach. It's the same guidance I would give you if you were sitting with me in my office. It takes a holistic, functional view, guiding you through what to look for, how to think about next steps, and what actually helps. Available now on Amazon. Link is in the show notes.
To back it up. Yeah. So we've gone from like anecdotal to best practices to ICAP putting out, actual guidelines. And then hopefully this research will help us get to like true standards of care. Right. So I have to ask you, what is it like stretching your own grandbaby? Are you able to like separate, or does it feel different, or what's it like?
That's a really great question. And it's both. It's like, I have been a clinician for so long. I mean, I'm used to supporting people through pain, especially as a midwife, right?
Right.
So
True.
pain, a baby crying, that doesn't usually bother me. I know what I'm doing. I mean, I once worked in a nursery with 14 crying babies, myself and a nurse's aide. So like I'm desensitized to that.
Right.
But yesterday, and the provider, we went to Dr. Joe Marola, who's in New Jersey with us here, and he's amazing. And he, the parents stay in the other room, and I was allowed in with the baby. And she's so strong. I had to actually help hold her. Like because she's 4 months old.
Yeah.
So I was holding her legs, and the assistants were like, "Thank you so much," because she's so strong. But it's like on and off. I was going, this is Isla. But it's okay. But she's almost done, and it was on and off and on and off. And then the stretches are tricky because I try to not let her see me.
Right. So she doesn't associate. Yeah.
And then I like go around the other side of her and start like making funny faces and making her laugh and stuff like that. So it's both. It's like, yes, clinically. And I'm going between like, that was enough. And, wait. No, we got to do it again,
Yes.
Yeah. The soft side
and
of me comes out.
also worrying about your daughter as well, right? So, because this is a dyad that you're training, so I'm doing these stretches. How's my daughter handling the fact that we're having to do this? That's heavy. That's hard.
Yes, yeah. She's, and this was a big deal for them. That's why, they put it off for this long, because they were worried about doing it, and things weren't that bad. Right? This was one of those. And one day I'll write up this case study because it was like an on the fence case, right? But now, what happens at around 3.5, 4 months, compensations start happening or falling apart, and things were getting a little hairy and some symptoms. And I was like, if we don't do it now, you're going to regret it. I can see the writing on the wall. And as soon as the release happened, we go, I brought her back to her mama, and she put her to breast, and she latched. And I said, how does it feel? And she said, it doesn't feel like anything now. And I said, but it did before. She said, yeah. So she wasn't realizing what she was feeling was a little bit uncomfortable because she's just a mellow, wonderful lady, my daughter-in-law.
Yes.
So she was like, yeah, it feels different. And then the other thing that we noticed right away is she's 4 months old, and she's been treated by an osteopath. And he kept saying, I know I've done as much as releasing tension. She's got a very tight lip tie, and I feel like all her tension is coming from there. And the lip tie was very tight, and it was very broad tissue-wise.
Yeah.
Right? So it's released. It looks beautiful today. As soon as we were inside, she used to keep her hands very fisted, and I was starting to get a little anxious about that because I'm like, at 4 months old, she should be able to hold things, and she really wasn't. In the room of recovery, while she's nursing, she opened her hands. And we go home, she's grabbing things, she's holding things.
Wow.
And her mom told me today that she started like on the floor. She's starting to creep. She's actually stretching out her toes better and using her toes to lift up. And she doesn't know that, my daughter-in-law is not educated in this. She doesn't know that has anything to do with the tightness in her body, So I'm like, well, that's it. All that tension is coming down,
That's amazing.
So,
It's all connected.
So it's all connected, right?
I'm so glad they did it.
Tongue to toes.
Yes. I'm glad they did it now and not when the baby's 2 years old with teeth and whatnot.
Yeah.
That's amazing.
Yeah. Exactly.
What a relief.
Exactly. So the other thing that I wanted to talk about the research is the tool you're using for tracking, because I have my course, my pro course, and I went through a lot of assessment tools in my course. But I didn't include the Infant Eat tool. And that was introduced to me at this latest conference. And I'm going to I'm going to actually do I'm going to do some cases using that myself so I get to know it. And then I want to add that to my course because I think that's an amazing tool after I've looked at it. So tell me a little bit about the Infant Eat tool.
It's very thorough. I really like how it is a validated tool, most importantly, right?
Mm-hmm.
So
Mm-hmm.
I like how it breaks down certain symptoms and it shows if this symptom has been more correlated with issues with lip tie or issues with tongue tie or both. Um,
Mm-hmm.
what's really nice about it is I'm just a very visual person, right? So to be able to do it at the consult, before the procedure, day of procedure. And then it's for the purpose of the study, we fill it out at the 1 week post-op and we fill it out at the 4 week post-op. That's just kind of the standard for the study.
Mm-hmm.
And it's nice because it's just a bunch of check marks and you can see
Mm-hmm.
how the check marks go from being more on the right side of the page over to the left side of the page as the journey goes on, meaning that symptoms are getting better. And there's
Mm-hmm.
other calculations that are involved too that can show you more information related to the data. But just from a
Mm-hmm.
clinician standpoint, being able to quickly see what the symptoms were and how they're improving over time is really, really helpful.
Yeah, and I like to use symptom checklists
Mhm.
when we're talking about is there reattachment, right? Because reattachment, as I believe it, isn't just what it looks like, it's functional.
That's
So,
right.
right? So we can see a new frenum, but if there's function, if the function is still better or no symptoms have reoccurred, then there's not reattachment because the whole purpose of this is function, not
Right.
what it looks like,
Yeah,
right?
it's
So
healing.
I
If it's
like
if
these
it's not
tools. Yeah.
reattachment, it's healing, right? Yeah.
Right. So like I like the flip tool is what I currently use and I've been using
Okay.
but this is very similar. So I'm going to try this one out too and see what I like better. And I actually asked my daughter-in-law to fill it out right before the release so we can track things and I can learn from her case,
Absolutely.
firsthand what changes for her and how the tool works, because I think that we need standardized assessment tools because this way we're speaking the
Absolutely.
same language and we're using tools that assess function, not just appearance, not just measuring,
That's right. That's right.
So,
Well, you have
okay,
to
I'm
let
going
me
to,
know which one you like better for use in your
yeah,
practice. I'm curious to
yeah.
hear some
I
follow-up
don't
from you on
know.
that.
From what I look at, if you're not doing research, even though Flip is validated too,
Right.
that's also a validated tool, the
Yep.
Flip tool, Dr. Agarwal's tool. But
Sure.
I think that might be a little simpler to use, like as far as parent use, but I have
Right.
to, jury's still out on that. So the other thing that I really like to talk about is this controversy that keeps coming up lately for me about whether lip ties are a thing and whether we
Mm.
can help function without touching the lip tie. And there's a new study that I just saw come across my socials with somebody who likes to criticize everything that we do, all about how there was this study and lip ties don't matter and blah, 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 blah. So just what are your thoughts? Because I like just hearing what I just told you about my granddaughter, like we almost didn't do the tongue.
Same.
Because we knew
I've
the
seen a
tension
lot
was
of those
coming from the lip.
cases. Right.
Yeah.
Or even the cheeks and
Right.
overuse of the lips and cheeks or just a tight oral
Mm-hmm.
orifice in general, where everything's just small and hard to get in and move around when it comes to feeding. But no, I have a number of cases that I've done. And, what we know is if you have a lip tie, you have a 90% chance of having a tongue tie, right? So I've had some kids with really, really bad lip ties, but I could not appreciate anything, even posterior tongue tie, even after doing therapy and stretches. It wasn't even like an embedded lingual frenum.
Mm-hmm.
And some of them we did just maxillary labial frenectomy. Some of them we also did maxillary buccal frenectomies. But
Mm-hmm.
just in doing that, just the overall facial tension changes. The gape is able to be bigger. And then I
Mm-hmm.
still am seeing the mandible drive forward on these kids that have these retrognathic mandibles. Like what
Mm-hmm.
I know now about ties, looking, being a pediatric dentist, I see kids of all ages. Almost every class 2, meaning overbite, like front to back overbite patient has some sort of tie.
Wow.
Well, even some of these kids that did not have tongue ties as infants, but had really bad lip ties and maybe even bad buccal ties, after doing the releases, the mandible still drove forward in a drastic way. And I don't know if it's just like overuse of certain things and just tension in general with underdevelopment of jaws, but it really just floored me and I know just in general, even without release of ties, the infant mandible does drive forward over time, but just extreme changes in a 1 month period on an infant after just releasing upper lip and upper buccals, even with the mandible and the patient's profile. Very interesting. I think the upper
Yeah.
lips and the
So
buccals
yeah,
don't get the
we
credit
definitely
they
need
deserve.
we definitely need more. Of course, we need more proof of that, but it's hard,
100%.
especially when you're individualizing care. So it just makes it hard to track things. But I think we're
Hmm.
on our way. We're in such a better position than we were like 10 years ago, where we couldn't show anybody why we were doing what we're doing, and we've changed practices based on
Right.
what's come out. So I think that's important too. But yeah, is there anything
Absolutely.
else about your practice that you'd like to share? Any pearls of wisdom that you've gained over your years of practice that you'd like to share with our
Oh my
audience?
goodness. So many. Where do I start, really? Um, So as you were talking about stretching the grandbaby, something that I was thinking about, I think you met Adrienne, my frenectomy coordinator, that came with me to Portland. A little
Mm-hmm.
line that she likes to use, and she encourages parents to say to themselves when they're stretching their children is, "I'm doing this for you, not to you. For you, not to you." And like we even have to tell ourselves that during the procedures sometimes as well, because it is a very emotional and
Mm-hmm.
taxing thing to do, right? Um,
Mm-hmm.
Also, a huge pearl is just having a frenectomy coordinator in general, where I have one assistant who pretty much takes care of this portion of my practice from the first phone call when a patient calls about coming in for a consult, a specialized consult, through the last post-op visit, just for that continuity
Mm-hmm.
of care. It just makes my life easier. It helps me communicate with my collaborative partners, my therapist, better. But that's been a huge change in a positive way for me. And block scheduling is really important to be able to, like, I had to rework things so many times to find the best way to add this type of treatment into my flow of practice, right? Because I'm still a normal pediatric dentist. I just happen to do a lot with airway and ties, right? So finding
Mm-hmm.
out how to incorporate that into my practice where it's efficient but yet still rewarding, and I know I'm helping people. I talk a lot
Mm-hmm.
about that. We also have a general anesthesia suite in my office, which is majorly helpful. I remember when I first started getting into this, and you would be on social media, and the big push was, you should never have to sedate a child to do this. It takes 2 seconds to do the release. Just hold them down real quick and get it done. And I'm talking about like toddlers, not
Mm-hmm.
even a 4 month old baby. And as a pediatric dentist, we're very trained in sedation, right? And we have hospital
Mm-hmm.
privileges and whatnot. But I actually came into this type of work when a general dentist in my town was doing this for a while, and he would treat infants 6 months and younger. And it
Mm-hmm.
just got to where he was having to do older and older babies, and it was getting harder and harder. And he was like, can you please start doing this, because I need help with my
Aw.
older children and older babies that need sedation. So one of my big things when I started doing this was raising awareness, or just like educating people on the idea that it's, yeah, if we can do something without sedation, great, but I'm going to do a much better release on your child, and I can actually suture this tongue and potentially get better healing if I do put this 18-month-old to sleep in
Right,
my
right,
general anesthesia suite in my practice, or in a hospital setting, right?
right.
So what's
Yeah,
unique
because there
about
are some practices that won't even touch those toddler kids
that's
because
right.
they, right? So if we don't want to have to wait until they're able to follow commands, if the problem is there now and the compensations are happening now, and you're talking about the palate not expanding and all the
Yeah.
things that need to happen if you wait too long, right?
That's exactly right. And to be able to just provide any level of sedation, from either no sedation with an infant swaddle wrap through general anesthesia if needed, it's really nice because we can take care of pretty much every patient that way.
Yeah. So I know that I've heard you speak at conferences a lot about the way your practice is set up. And, you know, you're one of the pros who has done this and gotten it to a point where it works for you. And I've heard younger dentists like picking your brain about it. And I think it's wonderful that you share, because we are all kind of paving the way for those who are going to come after us. You know, it's why I teach. It's why, you know, it's like, I don't want to be doing this forever. I want people to understand what I've learned. That's right. That I don't have to do this forever.
That's right. You got to pass it on, right? That's right.
Yeah. Because, you know, and now I'm up to grandbaby number 3, and someday that's all I want to do is play with my grandkids. But that's right. But I love what I do. And I love to teach, and I love to lecture. And especially because we get to collaborate and network and meet people like you and like all the lovely people that come to our conferences. And
absolutely. And you're really good at it.
Have a lot of fun too.
That's right. You're really good at it too. So
Thank you. So, Dr. Leroux, I'm going to let you go back to those babies who are waiting for you. Thank you so much for taking this time from your busy schedule. I hope to see you again soon. Keep doing the good work, and we'll chat soon.
You too, ma'am. Thanks so much for having me. Okay. Have a good summer.
This podcast is meant for education and conversation only. It is not medical advice and does not replace formal education, professional training, or individualized care from a qualified healthcare provider. Always seek appropriate guidance for individual concerns. The views and opinions shared by our guests are their own and do not necessarily reflect those of the host or tongue tie experts. Are you a healthcare professional working with breastfeeding infants? Wish you knew more about assessing and treating tongue ties? Earn continuing education credits and transform your practice with the Professional's Guide to Tongue Tie in the Breastfeeding Infant. It's perfect for any practitioner who works with infants and their mothers, especially those working through feeding challenges. Learn to identify who needs treatment, build a qualified care team, and provide holistic care options. Discover the ins and outs of frenotomy, including procedure preparation and best aftercare practices. By the end, you'll be confidently supporting breastfeeding families armed with the latest protocols and be part of an interdisciplinary community of experts just like you. Tongue ties are nothing new, but the right way to assess and treat them is. Ready to make a real difference? Join now and become a tongue tie expert. Sign up today at tonguetieexperts.net/professional and become the evidence-based resource that your community needs. To show my gratitude, I'm offering you a special discount as a podcast listener. Use code PODCAST40 to save 40% off today.